Good morning, good afternoon, and good evening from wherever you are. My name is Anafi Mataka from the African Society for Laboratory Medicine. Welcome to our May 2022 LabCoP Extended Echo Session. We are excited today to be hosting this from the beautiful southernmost part of the African continent. They call it the Rainbow Nation. The beautiful country of South Africa, where we are hosting our National Quality Laboratory Framework Workshop. Today, we want to touch on a very important topic, a topic that is at the hearts of nearly all of us, is the topic of tuberculosis. We all agree it is one of those most, I would want to use my sort of transliteration into my mother language. Is that one of those diseases that has always made us cry, if I were to put in that literal translation, because it has been there for a while, but we have not managed to do much about it, particularly when it comes to diagnostics. We all know the very difficult ways in which we try to diagnose TB. It is usually through one of those most so not pleasant samples that we collect, let alone that it is also very difficult to diagnose, particularly also in children. But the world has not stopped. Technology has not stopped working hard to try and find a solution to this. So in today's session, we want to discuss a guide which talks about more of these diagnostics that have been put in place, particularly following the recommendations by WHO, which point out that most of the cases that are symptomatic should actually get access to diagnostics using particularly a molecular test. And those that are confirmed positive need actually to be detected for resistance, at least for the first line drug rifampicin. And those that are positive for that first line detection need at least to go one more step further to at least get one rapid diagnostic test for at least fluoroquinolone. We all know this is important because TB is one of those most leading causes of death that we have. And given that we have the technology to try and change this, I think this is an opportune time to do so. In this session, we're also going to look further that this is not probably the first guideline that has come through. What is it that we can do to make sure that these guidelines are actually not just guidelines on the shelf, but guidelines that could actually be used by everyone who needs them. And to do so, I would like to call upon Dr. Patricia Hall Edison, who is the Vice Chair of the GLI and leads the TB and clinical monitoring team in the international branch of International Laboratory Branch at the US CDC, where she manages the whole national TB reference laboratory at the CDC in Atlanta, Georgia. She holds a PhD in microbiology and molecular genetics, as well as a Master of Science in Evolutionary Development. And she has about 19 years of experience in laboratory research, development, project management, strengthening TB systems in collaboration with a lot of ministries of health across the world. Just before she comes in, I would like to remind you of the key logistics for this session. We have French and English simultaneous interpretation. Please choose the language of your choice. All you need to look for is the sign of the globe. That is written interpretation if you are on a desktop, where you need to choose either French or English. Please do not remain in the mute section for you to be able to hear one or two of those. We will also have this presentation going for about 20 or 30 minutes, and then we get into some question and answer, where we shall also be joined by Herbert Mutunzi, who is a TB specialist in Zimbabwe, and Dr. Stephen John from Nigeria. Ladies and gentlemen, allow me to call upon Dr. Patricia Hall to take us through the presentation.
And good day, and thank you to each of you for joining us today to learn about the Global Laboratory Initiative and WHO approach to selecting one or more patient-centered, setting-specific molecular solutions for TB detection. I'd like to, before I launch into the presentation, acknowledge ASLM for this collaboration and for the opportunity that brings us together today. For those who may not be familiar, the Global Laboratory Initiative is a working group of the Stop TB Partnership, and we have WHO's Global TB Program as our secretariat. And so we're really nicely placed to bring together objective partners that support global laboratory and TB testing implementation and quality assurance into a core group of individuals. And we'll be sharing the link to the Global Laboratory Initiative website as one of the resources with today's talk. So in today's presentation, we'll review together the current overall and testing specific global targets associated with ending tuberculosis, a disease that many of you will know has more than 5.8 million new cases each year occurring globally. We'll then touch on where we are and where we could be heading as a global community toward achieving those targets. So as a bit of background, the world's first UN high-level meeting for the fight against TB occurred in September 2018, followed by rapid release of the current global plan to end TB guidance on the left, shown here by the document labeled with the paradigm shift. This is a costed plan and roadmap to achieve the targets and commitments set forth in the UN meeting's political declaration. And building on the successes of the HIV/AIDS epidemic control strategy that many of you will recognize, the global plan presented a 90-90-90 TB target framework shown here. This framework indicates that at least 90% of all people with TB should be reached and placed on appropriate treatment, emphasizing the importance of testing for TB infection, as well as TB diagnosis of both drug-sensitive and drug-resistant TB. The second 90 is nested within the first, wherein at least 90% of the most vulnerable and key populations should be reached, inclusive of patient-centered, targeted testing approaches, which we'll speak about a lot more today. And the third 90 is aimed at achieving at least 90% treatment success with a full complement of patient care, including quality assured treatment monitoring and cure confirmation testing services. Okay, but we're talking about testing today. So the 90-90-90 global overall targets are further supported by testing specific targets, which were recently summarized in the most recent WHO consolidated guidelines on the diagnosis of tuberculosis. The document is shown on the left here. These specify that all people with signs and symptoms of TB should receive a molecular WHO recommended diagnostic, or mWRD, to detect TB, as these methods represent a truly historic advancement in our ability to accurately detect TB in a short period of time, particularly when compared with the previously recommended smear microscopy and very lengthy culture methods of prior years. Then all people with bacteriologically confirmed TB should receive a rapid molecular test to detect resistance to at least the first-line anti-TB drug, rifampicin. And this is, Anafi was speaking to this at the beginning of our webinar today. And that lastly, all people with rifampicin-resistant TB receive a molecular test to detect resistance to at least the fluoroquinolones, which is a class or a group of drugs that are used particularly to treat drug-resistant TB. Unfortunately, despite these clear objectives, the 2021 WHO Global TB Report highlighted continued gaps in patient access to these essential TB testing services, where diagnostic cascade data shown here demonstrate that of the 5 million incident TB cases notified to WHO, only 48% received laboratory confirmation of their diagnosis, with only 68% of those receiving a molecular WHO recommended diagnostic test, or again, mWRD as labeled here. This means that only 33% of notified cases received mWRD testing to confirm their TB diagnosis. And of those confirmed, only 71% received rifampicin DST, falling well short of the 100% goal. If we now similarly look at the diagnostic cascade for drug-resistant TB on the right, of the 157,000 notified cases, including 84% with rifampicin or multi-drug resistant TB, only 53% received additional fluoroquinolone drug susceptibility testing to ensure the efficacy of their prescribed treatment regimen. Barriers to patient access to these essential TB testing services have been numerous and will be discussed more, no doubt, by our panelists today. But we have certainly included gaps in strategic planning and lack of comprehensive health system network review in many settings under this list. These have prevented programs from ensuring in all cases that tests are available where and when patients need them most. To in part address these gaps, the WHO, World Health Organization, has been hard at work rapidly expanding global guidance to reflect the latest evidence-based tests advances in TB testing. This is to ensure that we have tests to meet patient needs. Over the past year, WHO updated guidelines related to the critical concentration of medicines used for culture-based drug susceptibility testing, endorsed a suite of molecular tests for TB and DRTB detection. We'll be talking about these more. Released updated consolidated guidelines and operational handbooks for both TB screening and diagnosis that include practical algorithms on test application, as well as information sheets for the newly recommended molecular assays. Released guidance on genomic sequencing technology use and result interpretation for DRTB surveillance, and formed a new diagnostic evaluation pathway to speed objective assessment of new diagnostic products. Policy statements recommending instruments for near point of care, second-line drug susceptibility testing for TB, and new TB infection skin tests are shown here as example products from that group. All of this is aimed at speeding and expanding the availability of differing tests to meet patient-specific needs. And to give you a sense of the scale of these changes, let's review only the newly recommended tests as they relate to patient testing across the TB clinical spectrum, shown here by the medical schematic, where first respiration-based transmission occurs, followed by TB infection, and where uncontrolled within the lungs, you have mycobacterial replication and resultant pathology that becomes known as TB disease. And then finally, treatment and cure. First, recommendations for next generation sequencing technologies and tests supported adoption of these high fidelity, albeit high cost, approaches for drug-resistant TB surveillance and outbreak response. Next, 2 new blood-based interferon gamma release assays were recommended for detection of latent TB infection, and mWRD as well as C-reactive protein tests were recommended for the first time to screen for TB, and this is active TB among persons living with HIV, alongside, for example, chest x-rays with optional computer automated detection capabilities. And lastly, and most importantly for today, a suite of multi-disease instruments and molecular tests were recommended for TB diagnostic, first and second line drug susceptibility testing. Of note to this audience, many of these instruments can accommodate differing disease scopes with options for HIV, HCV, HBV, HPV, MRSA, sexually transmitted infections, SARS-CoV-2, and or influenza tests, expanding options for, again, more holistic patient need-driven testing solutions. And instead of producing policy guidance specific for individual manufacturer-specific tests, WHO will now recommend classes of TB diagnostic tests. So as opposed to the expert MTB-RIF standalone policy that we had years back, we will now hear about tests being added to classes, where each class represents a group of products with similar underlying technology, complexity, and performance characteristics. The classes for the newly endorsed TB nucleic acid amplification tests, or NAATs or NATs, are shown here, where, for example, the expert MTB XDR cartridge is shown in the middle of the table and is classified as a low complexity automated NAT, or LC-ANAT for short. With all of these new testing options comes opportunities for TB testing network customization for national and subnational TB programs, communities, community organizations, and patients, where all mWRDs have good sensitivity and specificity for the detection of mycobacteria, which is the mycobacteria that causes TB disease. And most, but not all mWRDs that detect TB can also detect drug-resistant associated mutations. Among those with DST capacity, all detect rifampicin resistance, some detect both RIF and INH resistance, and some detect rifampicin, isoniazid, fluoroquinolone, amikacin, pyrazinamide, ethionamide, or prothionamide resistance. Lastly, all mWRDs and their associated equipment and instrumentation vary in their technical specifications and requirements, not just in assay complexity, as captured by the new technology class scheme, but also in capacity, their testing times, their infrastructure needs, and other practical considerations. So with all of these new variable testing options, it leads to the important question, how to go about selecting one or more of these settings of these mWRDs for setting-specific implementation. And this is where the manual that we're going to discuss today fits in. The Global Laboratory Initiative, or GLI, and WHO have now launched a new manual to be used as a tool to address this question. It's entitled the Manual for Selection of Molecular WHO Recommended Rapid Diagnostics, or again, mWRD tests for detection of TB and drug-resistant TB. The manual describes a stepwise process for suitable mWRD identification and selection that is driven by setting-specific patient-centered diagnostic testing needs. It considers the ability of recommended mWRDs to meet a setting's testing needs based on factors like their national policies, their subnational epidemiology, the design of their testing network, and the availability of their specimen referral systems. And lastly, guides users to consider the feasibility of suitable mWRD implementation for their setting based on practical considerations, such as each setting's registration and importation requirements or supply chain structure, service and maintenance needs, and other factors. So let's get into the manual a little bit now, and we're going to take a tour together. The new manual is organized into a background section with an introduction and manual scope discussion, into two parts, where part A focuses on identifying and considering the implementation of suitable mWRDs for your particular setting, and part B presents a wealth of suggested reading links and further reading resources supported by a comprehensive list of references, which are followed then by two annexes, which serve as resources for suitable mWRD cross-comparison and some discussion on diagnostic network optimization, which is an important and related topic to some of the activities in the manual. So let's start with the tests included in the manual for selection. And this is just a shot that I'm showing of one of the pages, but will give you an idea of the formatting and the structure of the manual. So the tests included, these include the initial test for detection of TB or diagnosis of TB without drug resistance detection, which are listed here. There's initial tests for diagnosis of TB with resistance detection, and the follow-on molecular diagnostic and drug susceptibility tests, which are all considered as part of the initial test identification and selection processes. Notice that these tests incorporate different types of technology and WHO classes, and they differ in their resistance detection capabilities here. However, it's important to note, as just a side point before we move on, that while this manual only focuses on mWRDs, TB culture and phenotypic drug susceptibility testing remain crucial for TB treatment monitoring and drug susceptibility testing for new TB drugs for which we don't yet have molecular tests. Linkages from the initial mWRD testing services to culture laboratories will also therefore be considered as part of a holistic testing network and are included as a final step in this stepwise process, even though they're not listed in this table. So now let's look at the meat of the manual, the stepwise process that is outlined for mWRD selection, and this is outlined in Part A. So first is the data collection and analysis process, where data is needed to understand the clinical and testing context for each user setting. And then the data collected may be analyzed, as shown in step 2 here, and the outputs used to inform mWRD selection, which is the final step, or step 3. The first type of data collected are the national strategic priorities and policies highlighted here, which can be used to identify the primary uses of the tests across all patients, as well as for key and vulnerable persons, which is that second 90, right? So that's important to include. Next, the national and subnational drug susceptible, resistant, co-disease, and pediatric TB testing epidemiology, along with any other key or vulnerable populations that need to be considered in your setting, highlighted here in purple, are collected to identify the types and distribution of specific patient populations in the country that require access to mWRD testing. Then, data for the number and location of health facilities serving those patients, testing their samples, as well as the specimen referral linkages between those site types are reviewed and combined with the first 2 data streams that can be used in a diagnostic network analysis to estimate the testing need, the demand at the mWRD testing sites, and the availability of specimen referral systems to ensure patient access to both drug-sensitive and drug-resistant testing services. This analysis can also be reviewed against the identified mWRD capabilities throughout the patient activities in the second data set, as well as the national strategic priorities, in order to make sure that the identified mWRDs meet both programmatic and patient demands as the final output here. And lastly, there are testing site resource data to be collected and analyzed to identify both the capabilities and resources at each existing or potential testing sites that would be required to support low, moderate, or high complexity testing according to the new WHO technology classes and instrument specifications. These data may be combined with workload or other data to inform practical considerations for test selection and implementation. Okay, so this is all part 1A1, right? This is the data collection and analysis. And once completed, these data analyses are then used to inform each step of a multi-step decision pathway, which we will walk through now for identification of the suitable mWRDs. First, the diagnostic network analysis or assessment data are used to review the specimen collection sites and referral linkages to determine whether they are functional and efficient to provide patients the access they need to testing services. If not, the user is prompted to consider improvement or establishment of a referral system or establish test sites, on-site testing services, depending on the patient need and the programmatic need. All of these collection site and referral data sets are then combined for each testing network mWRD testing site. So you can see here it says combine all data from the referring collection sites so that all of that is considered when reviewing each testing site. Then the National Strategic Plan and EPI data, as shown here on the left, are used to determine whether each site requires the detection of TB, shown in orange, TB and rifampicin resistance, shown in green, or TB, rifampicin, and other resistances, shown in blue. The EPI and diagnostic network analysis findings can then be used to inform whether the testing site requires low or high throughput to meet patient demand for the test type selected. And this is important because we've mentioned the capacity of these tests differs and the capacity of the instruments differs. And by further considering test site resource information, the site may be classified as suitable for low or moderate complexity testing. So for example, if you only need low throughput and the facility is suitable for low complexity testing, then you will go down this pathway. Whereas if you need high throughput, but the facility is suitable for low complexity and moderate complexity testing, then you have both of these pathways as further options that we'll get to momentarily. At this point, suitable mWRDs are listed, and you can see the test names listed here for each column of the pathway, each of which may require follow-on testing, as I mentioned earlier, or referral for additional drug susceptibility testing or other TB culture-based services to ensure TB-positive patients receive holistic testing services to guide their treatment needs. However, keen observers of this tour will note that the decision pathway ends in a list of multiple suitable mWRDs to meet each testing site's need. These will, of course, require cross-comparison for selection of one or more testing technologies for implementation. So, for example, if we go back to this high throughput need site that requires testing for TB and rifampicin-resistant TB, we can see that the facility is suitable for moderate complexity testing, which gives it all of these options. And these will need to then be compared against the programmatic and patient needs for which test to implement. And this is where part A3 comes in, with considerations for suitable mWRD implementation. While we won't go through this section in detail, I will review that it proposes that users review their network-wide and site-specific lists of suitable mWRDs alongside their country-specific considerations for finance and regulation, import and regulation of tests and associated equipment and instrumentation, infrastructure and human resource requirements, instrument and test specifications, as well as end-user values and preferences for tests and testing experiences. And this is not the first place, but an important place to stop and mention the importance of community-based organizations, as well as patient advocacy and support groups as stakeholders in this process. And these considerations are then well supported by the manual's annexes, which, even though they're listed as annexes, should not be overlooked. Annex 1 provides users with a list of questions to consider when comparing their suitable mWRDs for selection. Questions cover the categories shown here, inclusive of considerations for WHO recommendations for mWRD use and their performance, the costs associated with testing, not just implementation or commodities, but also operating costs and potential cross-disease program sharing in today's modern world, procurement and supply chain requirements, instrument service and maintenance requirements, facility requirements, particularly biosafety, power supply, and connectivity potentials, and human resource requirements as well. These are things like workload, test complexity. Are there testers or laboratorians available already that can do moderate or high complexity training, or is that a training need that would need to be added on, for example? So an example question in this section is, what level of instrument capacity or tests per day is needed to meet the anticipated patient demand for testing at the mWRD testing site? So again, that's what level of instrumentation capacity or tests per day is needed. This brings us to Annex 2, mWRD test specifications, where the tests are described according to columns. You can see the test names here. And where the tests, in answer to our sample question, the capacity is shown as the third row right here, where you can see, apologies, that the capacity ranges from 12 tests all the way up to 1,056 tests as a maximum number of tests that can be completed in a workday. And these obviously meet very different levels of patient demand and patient need, and also have different infrastructure requirements. They also, of course, have differences in drug-resistant type detected, but also the required instrumentation available with different costs associated. And this is an abbreviated view of this column, so there are more specifications included than what is shown here. This is simply an example for today's overview. So that ends our tour as an overview of the manual, and this brings us to our key messages of the day. So in summary, TB remains a global health crisis, with gaps in patient access to diagnostic and drug susceptibility testing that truly require an urgent need to be immediately addressed. The TB testing landscape is rapidly expanding, which is great, and it's providing more options for patient-centered testing strategies. But these must be supported with selection and implementation that's guided by national TB and TB laboratories' strategic planning efforts to build effective, sustainable testing systems. The TB test selection and the associated network analyses should be guided by setting-specific patient-level and programmatic needs, should be driven by a wide variety of setting-specific data, and recognizing that this is a heavy data lift Once done, this can be iteratively reviewed and updated and is always going to be needed. So the fact that it's a stepwise process is no accident. That is very much to make sure that the data are prioritized and that they can be collected according to priority in order to guide this process as well as future processes. That all of these processes are completed with input from community organizations and patient advocacy or even patient or survivor groups, and matched with considerations for implementation, incorporating the global and setting-specific lessons learned, which is important for the technology-specific lessons in particular, and that advances in TB prevention, case finding, and treatment provide opportunities for patient-tailored care to end TB and achieve those overall global 90-90-90 TB targets. So with that, I'd like to acknowledge the following people, specifically Dr. Tom Shenik, who is the GLI Manual lead author and is a TB independent consultant, Elisa Tagliani, who is the GLI Core Group Chair, Charlie Nathanson, who is our WHO GLI Core Group Secretariat, Marguerite Masingo, who's a GLI Core Group member and Senior TB Advisor at ASLM, all of the GLI Core Group members, those that consulted on the manual, and of course the ASLM LabCoP team for collaborating with us and inviting us to be a part of this webinar today. With that, thank you very much, and back to you, ASLM team.
Thank you, Patricia, for the wonderful presentation. Somebody has just said awesome. Indeed, it was an awesome presentation. Colleagues, I want to remind you that we have the chat box where you can put your comments and questions in there. Then we can take the questions as they come through. Also reminding those that have just joined that we have simultaneous language interpretation, English or French. So you just need to choose the language of your choice. We would like to go in and take a few questions that are coming through, particularly moving on with the program. And I'm checking here for some questions as they are coming through. I would like to shift gears and, get on to a few questions that are coming through. I would like to call upon really basing on Patricia's presentation. I think a few keywords kept on coming through, especially when you were doing your final remarks. It was patient something, even on your second slide. Let me start from your title. You said setting patient-centered services. And you also talked about 90, 90, 90. It was all patient-centered. And we know that African countries, I think at least many of us, we have various context-specific challenges, particularly when we want to reach vulnerable populations. And I would like to call upon Dr. Stephen John. Dr. Stephen John is actually a senior TB, is a director of planning, research and statistics and at the Adawalma State University at the Ministry of Health in Nigeria. He is also a patient advocate when it comes to TB issues. So Dr. Stephen, in your home country, for example, we know we have several populations. Some of them they are pastoralists, some of them are nomadic, refugees, and all these also need to access care. Could you expand on some of these obstacles that I have mentioned, particularly with regards to today's topic, on how we can be able to use these diagnostics that are being recommended by WHO to actually reach these communities at the last mile?
Thank you very much, Anafi, and thank you once again, Patricia, for this stimulating and great presentation. Of course, in Nigeria, we have huge numbers of these vulnerable populations. Nomadic people are close to 10 million. You have a displaced person from the Northeast Boko Haram insurgency, not to mention other crises around, running into 3 million. Then you have refugees coming into the country from the southern part of Cameroon. So we have a buildup continuously of these key populations in the country. Now, the challenges that are associated with this group are quite similar. First, you see that they are remotely located. They don't come where you have the generality of the population. If you look at the nomadic people, they like to be so far away where they could support the grazing, their herding, you know, taking care of their animals, you know. So they want to be so far away where there are greener pasture and water, you know, free without any kind of hindrance from any population. So if you listen to the news these days, you will hear about farmer-herder clashes, because the farming activities are encroaching on the cattle routes, so it's causing a lot of problem. So the remoteness is getting closer to the cities as time continues. And then for displaced people, they also want to settle where they can do something like, for instance, farming. They go into host communities, we call them, and these are not actually easily accessed. They are all in a hard to reach location. And in worst case scenario, that's of the refugees who are afraid of the new kind of scenario or environment they find themselves. So they like also to stay very remotely and then to farm to feed their families. So these are some of the challenges that these people experience. Another key challenge is the conservative nature of these key populations. For example, nomadic people, they don't open up to you. You know, you have to be like maybe walking through one of them or be acceptable to them before they could open up to you. So they look at you suspiciously. So whatever services, health services that you bring to them, you don't just succeed like that without actually getting their complete buy-in. They have a structure that you have to follow. They have key stakeholders that you must engage. If you don't do that, then you will not make any headway with them. And then talking about displaced people, they are worrying a lot about feeding because their nutritional status is so poor. So when you start talking health, they will not listen. So you have to kind of work very closely with the people that provide such kind of support, and then you can now take a ride, you can leverage on this and deliver whatever you come with as a health service provider. Then the refugees also, they have their own conservative nature. They're also looking at you suspiciously. They don't know whether you're going to report them to people that are chasing them for where they're coming. So they hardly open up to people. So these groups, one thing they have in common also is this conservativeness, and you must work towards breaking in before you are accepted, before you start getting any results with delivery of any kind of services. Then a third crucial challenge that they face is the cultural barriers. There's this across these key populations, not only these ones, but even others. They have this concept of a household head who makes decisions for everything. So nothing can happen in their household without the decision, without getting the nod of this particular household head. So it is important to understand this kind of concept if you want to really make a headway. Then, of course, they also have this a culture of placing more value on the male child. So when it comes to illnesses in the house, if it is the male child that is affected, you see the aggressiveness, the proactiveness of the household head and people in seeking care for this male child is usually much more positive than if it's a female child. This is something that we've seen common also across key populations. Then they have a strong connection.
Yes, I don't mean to cut you. So given this context that you have given with this example kind of population, how can this guidance that has been presented here contribute to some of these challenges?
Well, definitely, this is the guidance that is coming now with this new diagnostics is a welcome development, because for decades we've been looking for how to really get to diagnose TB in a faster way. So these people are remotely located, and if they are in a place where you don't have electricity, so we are looking for this kind of diagnostics that will be easily administered, that can give a quick diagnosis and a turnaround time, so that at the end of the day, we leave the linkage to care with the volunteers that are being empowered day in, day out. So this guideline will provide that platform that is required to make sure that we reach these people because of these difficulties that we're talking about. Then, of course, the guideline also comes with the needed information that will serve as an important advocacy tool, you know, when it comes to its domestication, because people want to know what is contained in this guideline, what is this new diagnostics we're talking about. You can't just roll it out without actually passing this particular information. It gives a very good opportunity also to use as an advocacy tool, because with it in your hand, having understand it, then you can talk to key stakeholders, then it can be accepted, then it can lead finally to the standardization of practices, because if not, you still find people using diagnostics that are not approved in the country. So with the coming of the guideline, it comes with a chance of having a standardized practice when it comes to diagnosis of TB.
All right. Thanks a lot, Dr. Stevens. I see for actually giving us into context why we are doing this. It's all about the patients that we need to look out for. So I want to come back to some of the questions that are coming there, and that they are actually going back to Patricia's presentation. I see people talking about quite a number of issues, important issues there. If you see, people are talking about service contracts, people are talking about sample transport. I see also things that have been mentioned like supply chain. So Patricia, in the guide that you presented, you looked at 3 key areas. There was an issue of, the collecting the data, making the decision pathway, and then ultimately implementation. And most of these questions are more of implementation. I just wanted to come there as this the guide was being developed. What were some of the considerations that were taken into within this guidance? I know you moved quite fast, but what were some of the considerations taken into in this guidance to try and address some of these key system issues?
Yes, thank you so much. And so, the first thing that comes to mind as far as a consideration for manual development when it comes particularly to the implementation considerations was to split out the types of data in that first step, so the data collection step, into different categories that are needed and that would cover some of the considerations and ideally incorporate lessons learned from prior molecular testing technologies. So for example, I think Stephen spoke really very well, I think, to the importance of having differentiated testing strategies for different populations and really understanding where those key and vulnerable populations are and what kind of tests they need. Are they at high risk for drug-resistant TB? Do they need access to that? Or to further drug resistance testing beyond rifampicin resistance. And so that's why it's broken out by your national strategic policies, and then you're setting specific sub-national distribution of the different populations that need those tests. The last category there for data collection is around the practical considerations and infrastructure for your testing sites. I think we've seen with GeneXpert, and particularly over the years, instruments being procured and placed in settings that may not have stable power, and they weren't procured necessarily with universal power supplies in order to ensure that. We learned the lessons over the years of implementing solar panels in certain settings. Nigeria is a key example of that, Stephen. And the service and maintenance needs of putting out instrumentation that may not be truly point of care, but that requires routine service and maintenance. And so that's where, for example, some of these decentralized or mobile settings might benefit from some of the more true point of care instruments that are dust savvy and that can be taken in the back of a truck somewhere and brought out into the community for testing. Whereas you wouldn't use that same instrument, right, if you're in the middle of Kampala, for example. That may not be as needed because you have referral systems and you have instrument types there that are already on the ground and in place that can do very high throughput, high capacity testing. So I think a lot of these implementation considerations are in the data collection phase, so with a nod to that. And then second, I would highlight the considerations aspect. So that's section A3 of the manual, where you really take into account things like regulatory status. Cost is a huge one. And so I will point out that, to my knowledge, the Stop TB Global Drug Facility is still working on some of the unit costs for some of the new tests with the manufacturers, but as they become available, they should be listed there in the Global Drug Facility catalog, and I've posted that in the chat because we've had quite a few questions around cost. But I think that's another lesson learned from GeneXpert implementation, right? That the costs are not just the tests. The cost is the routine service and maintenance, the diagnostic connectivity solutions that go with it. So I think at every phase, really, Anafi, of everything from selection, from data collection to implementation, really understanding what our lessons learned are and what the practical realities are should help inform some of that selection. And that implementation should be stepwise too, right? So we're not trying to do everything all at once, but there are clear priorities in place through those strategic plans, ideally.
Yeah. Thanks a lot, Patricia. Very important, I think, considerations and the summary to that question. I want to move on to the perspective of the TB programs, and I'll take advantage of Herbert. Herbert is a former program manager in Zimbabwe, and he's now the senior TB diagnostic specialist for the infectious disease detection and surveillance IDDS project in Zimbabwe. Herbert, some of these challenges that have been mentioned, I'm sure you are quite familiar with them. And I would ask this question in two perspectives. One, from your personal point of view, what are some of these issues that normally we get these guidelines coming through, but one way or the other, they are not eventually sort of translated into implementation that Patricia has been asking. And what is the perspective of the TB program? How can they contribute to solve these issues?
Thank you very much, Anafi. I hope you can hear me clearly.
Yes, please go
Thank
ahead.
you. Yeah, thank you very much for giving me this opportunity to share our experiences. And I was a TB lab focal person with the National TB Control Program in Zimbabwe. And thank you very much, Patricia, for the very comprehensive overview. I will begin by saying, of course, guidelines are valuable tools, especially now that for TB, we have multiple diagnostic tools for the diagnosis of TB and drug resistance. Both compared to the yesteryears where we were only relying with smear microscopy, I think this is valuable. But however, despite these guidelines coming in from the community, what we see is that the adoption and implementation of these guidelines is often slow and complicated, as I will discuss later on. Of course, excessive implementation of these new guidelines requires a thorough or in-depth assessment of barriers and the use of the adequate strategies to overcome these barriers. My experience with the rollout of these new diagnostic tools, we see that we faced a lot of some of these barriers in terms of the healthcare knowledge, where most of the healthcare workers lacked awareness about these guidelines. Having some experience in conducting external TB program reviews and the TB diagnostic network assessments in a couple of countries, we have observed that in as much as the guidelines might be there at the national level or the SOPs or algorithms, when you go down to that sub-national level, even at implementation levels, you start probably not seeing them or actually see odd versions of these same guidelines. So in terms of standardization of implementation, it becomes complicated. So, and sometimes, the healthcare workers might be looking at familiarity of these guidelines because they've not seen them or they've not heard about them. And sometimes it's a question of attitude of the healthcare workers, where there is a disagreement with what is recommended, what is in the guidelines from the WHO and the international community. I'll give an example of one of the labs that we visited, where during one of these diagnostic network assessments, so they actually said, no, we cannot use the Ultra cartridge because they were citing one article which was contrary to what is in the WHO guidelines. So this is some of these issues that are at personal level. So I think in terms of overcoming these challenges, there's a very great knowledge of proper dissemination of these guidelines. All the healthcare workers have this knowledge, and they are able to refer to it, they are able to relate to it. And also education and trainings of these healthcare workers are actually important to break barriers. So there are also very, a number of strategies that can be used to disseminate these guidelines. Can be through email, platforms like this one that we are having, the webinar sessions or other. Even I think also involving the academia or the teaching institutions, where during the trainings, the trainees are also able to get some feel what they are taught about this new guideline. I know they are always evolving, but it's also very important. But one other issue is related to the guideline itself, which is basically into the process of developing these guidelines and establishing them so that they are available and easy to use. Sometimes these guidelines might be very complex or complicated. They might be theoretical in nature, but so when we want to implement them at the grassroots level or the implementation level, we see some bottlenecks because the healthcare workers feel that they cannot interpret these guidelines well. And I mentioned about sometimes when you go down, you see different versions of these same guidelines. So I think one other strategy that we used in Zimbabwe was whenever we guideline, we need to withdraw the outdated guidelines to minimize confusion when at diagnostic levels or even at treatment levels. But there are also issues to do with the organizations, which are mainly like external to the organization, because I think it was mentioned about the referral system, which is very key, because sometimes diagnostic tools, like has been presented by Patricia, they are tests like blind probe assays. So in terms of now trying to move the specimens to these centralized labs, we have been facing challenges, or we have had challenges. So it's very important that when countries try to adopt and implement these new guidelines, they also take into consideration these challenges. And also I think some countries also have in terms of before they introduce any new diagnostic tools. So they need to start the validation process of this new tool before I think this is something that can be taken into consideration. And I think at this stage, we probably have some resources to implement these molecular WRDs. But when we started, I think early on after the announcement of the extract test, we had some issues to do with the resources to say, probably even when the WHO came up with the recommendation that it says to be the initial diagnostic tool for all presumptive TB cases. This was a big debate at some stage where we're saying, okay, can we be able to test everyone who comes into our health facilities? I think those are some of the issues that I was able to respond to. Yeah.
Thanks a lot, Herbert. I think very wise words indeed on how we can be better able to move forward in really using these guidelines. I really acknowledge that the 1 hour that we have is certainly not enough to really go deeper into the guidelines, but I'm tempted to take 1 or 2 interesting questions that are in the chat. Thanks a lot for so much activity in the chat, and thanks, Patricia, for responding to some of them. I think there was one question which talked about something that is all dear to us. It's really diagnosis in children. What does the guideline say with regards to this aspect? Margarita has tried to respond, but for the benefit of everyone, maybe Patricia, you can touch that bit, and then maybe also speak to the issue of advocacy. What does GLI do in this case? So two questions.
Great. So I'll answer the advocacy question first, and then may have you retouch on the first one, Anafi. But for advocacy, GLI itself is not strictly an advocacy group. Instead, we're a group of objective experts that come together from different organizations with expertise in TB laboratory implementation and guideline development or guidance development, if you will. In order to develop and put out, like this manual today, practical guidance and tools for building and sustaining the TB diagnostic networks. Having said that, I think some of what we do is to support in that development, implementation of WHO policy guidance, integration of laboratory networks, things like human resource capacity development. We have a couple of activities going on that way. And in those ways, when we put out the products and develop them, we are able to comment and highlight on both the challenges and the opportunities for improvement. And so we're an added voice, I think, in some ways, to that advocacy message that goes out. And certainly some of the GLI core group members and their organizations participate in other advocacy efforts, and either personally or professionally. And then Anafi, could you touch on the first question one more time? Sorry, I was focused on the advocacy one.
Okay, because it eluded me, but it was talking about what does the guideline sort of direct us in terms of diagnosis of childhood TB? Is there any specific guidance which appropriate molecular diagnostic test has been recommended by WHO?
Thanks, and thanks for picking up on that. There have been multiple questions about childhood TB and a lot of enthusiasm, I think, around stool in the chat. So I will say that the most recent WHO consolidated guidelines on pediatric TB were released in March on World TB Day. They are available on the WHO website. And so they will have the latest summary of the diagnostic tests and the sample types that are recommended. At the moment, stool-based testing is only recommended for the Cepheid Expert MTB-RIF and Expert MTB-RIF Ultra tests. That is not because the others won't work on stool, it's just because there was not sufficient evidence for WHO to review and make policy on it. This is a great opportunity for those of you interested or involved in operational research to be collecting and providing some of this evidence for WHO to expand that policy. But stool, nasopharyngeal aspirates, as well as, of course, induced sputum and expectorated sputum are all sample types for the diagnosis of childhood TB. And thank you, Elisa, for putting the manual on stool processing that GLI just released in the chat as well. So I think there are lots of good resources out there, and wish we had more time to speak about that more, but thanks for the questions.
Thank you, Patricia. Important indeed. Just like many other diseases, alternative sample types will always be key to make sure that we reach all the populations that we have. In closing this, I think I want to just ask Stephen in about 30 minutes, 30 seconds or so. I mean, we all do this for the patients, and we are talking about easy ways of doing things, reaching out to the patients where they are. How can we best, you know, in your view, from the civil society perspective, how can we best improve this continuum of diagnostic services between the laboratory and the communities to ensure optimal outreach? Just in a short.
Thank you. Yeah, I think the civil society has a very important role to play. And, you know, these days, especially when it comes to getting the awareness out there, you know, advocating to the right people that matter. So, and then especially when it comes to the NTP, the national TB programs, you know, who are a key player in this particular relationship that we're describing. The civil society have a very important role to play here by stepping up this advocacy and awareness creation. Then, of course, sometimes there are challenges. There are challenges that are being experienced with you know, provision of the technical support that is required for the understanding. You know, you see that the civil society find themselves in meetings where they support the national program to make sure that they bridge this particular link between the laboratorians and then the other programmers. So this is one very important area also that they've developed. to the cost of this particular process. Then lastly, always we're working for the patient, like you said. The community matters a lot. The accountability is very important. Then the civil society also will play a very important role here in making sure that they bring accountability to this particular consumers of service. So over. Thank you.
Thank you, Stephen. I want to give this last few seconds back to Patricia for the benefit of those that are just joining or those that joined late. What are the key messages that we would want to part with, Patricia?
Sure, key messages. TB remains a public health crisis. It's something that we just can't forget and we have to urgently address. And ideally, we address that all together with all the relevant stakeholders from the patient level to the civil society and community level to the national level, and these across our various settings in order to pull together an understanding of where patients have access now and where they don't, what the policies and priorities are in these settings, and then use a data-driven approach to select technologies and tests and approaches to testing that meet patient needs and that meet programmatic needs in order to work towards ending TB.
Thank you, Patricia. I would not comment on that because I'll be spoiling it. Very nice summary indeed. Colleagues, it has been a wonderful 1 hour, which went very fast. I would just want to appreciate all of you for coming through in your huge numbers as usual. We always cherish this platform for the LabCoP to be able to share knowledge, best practices, create new knowledge as well. On your screens right now is a certificate code that shows you how you can go to the ASLM Academy and be able to download your certificate. I'm picking an echo here. Then also on your screen is the feedback coming from you with regards to how this session went. We realize this is valuable to all of you, and we hope to continue bringing such topics for the betterment of our communities and the world at large. Please watch out for your inboxes for the next session that is coming very soon. Till we meet again, thank you and goodbye.
Thank you, Anafi. Thank you all. Goodbye.
Thank you so much, Anafi.
Goodbye.